So this is kind of dovetailing off of last week. I had shown this case, and let's see if so this is a patient with ankylosing spondylitis, and we had kind of gone through his correction and his x-rays, and we were really satisfied with, well, I was really satisfied with the correction that we got. And I did mention when I was presenting this case that we had lost signals, unfortunately, for a brief period of time during surgery. So I wanted to kind of discuss neurologic complications as they relate to vertebral column resection. So this is just a little bit of a literature review. So this posterior vertebral column resection for severe deformity, Dr. Lanke's group, 35 patients, they looked at posterior only vertebral column resection. And they had in their series, they had a 6% loss of neuromonitoring data during the vertebrectomy closure. So that was 2 patients out of their group, and then in one of those patients, the data was lost with closure of the vertebrectomy site, and they postulated that this was due to vertebral subluxation, and it returned after a reopening of the osteotomy site and then closure of that site over a cage. In the other patient, in their paper, they noted that overshortening of the spinal cord had occurred when they did close over a cage, and intraoperative neuromonitoring data returned after the release of the closure and the cage removal. So this basically just kind of talking about the different ways that in the different sort of things that can be impactful during these operations as to when the signals can be lost. Both patients did wake up with normal neuro exams. I'll keep going here. This is another paper, Dr. Scheimer's group, I think he's out of Virginia. They looked at, this was a large multi-center study, looked at 132 patients who underwent 3-column osteotomy. They showed that, obviously 3-column osteotomy patients had higher ABLs, but they showed that they had similar complication rates and similar rates of new neurodeficits post-operatively. And again, we know that these patients have high complication rates. Their group, this multi-center study showed 49.3% overall complication rate and 8.7% new neurodeficit rate. Another paper, this is out of the focus group with patients in particular that were operated on in Ghana. They had 45 patients with posterior vertebral column resection. These are mostly for severe congenital deformities, and some of the patients, some of them had congenital deformities, but most of them were severe scoliosis or kyphoscoliosis relative to TB. So intraoperative neuromonitoring changes occurred in 10 patients. That was 22%. And they stated these were due to hypotension or extreme cord manipulation or at the moment of the osteotomy closure. One patient lost signals intraoperatively and progressed to a complete spinal cord injury, unfortunately. 2 patients had an isolated nerve root injury and 1 transient left L1 injury and 1 permanent S1 nerve root injury. 2 patients suffered from advancement of their myelopathy despite good correction and decompression. This is a study looking at neuromonitoring in severe deformities that underwent posterior vertebral column resection. This is out of China, 82 cases with severe deformity at a single institution. 39 neuromonitoring events occurred. That was 32% of the cases. And these events they noted were more likely to occur in larger scoliosis and kyphosis, larger osteotomy closure distance, more halogravity traction, more screw insertion, higher posterior vertebral column resection segments, so higher up in the spine. 6 events were during screw insertion, 20 during osteotomy, 9 during osteotomy gap closure, and 4 during deformity correction. New post-op deficits in 13.4%. and then 1 was a complete paraplegia. This is a multi-center, sorry, like a large meta-analysis of a lot of different papers. I'm going to skip this. This next paper showed that this is actually from the prior paper. Excuse me, I think my slides got mixed up, but this is showing the different time points when these events were noted. And so you had most of the neuromonitoring events were during osteotomy, which is when our neuromonitoring alerts were also. And then these are detailed reasons why. So the most was because of bony compression along the site, at the site of the osteotomy site. So this is a paper that I was able to find that looked at the response to neuromonitoring changes during these osteotomies. And it's a retrospective review of all of neuromonitoring changes during 3-column osteotomy, and basically looked at, it showed that neuromonitoring alerts had occurred in 37 posterior only 3-column osteotomies out of their cohort. They divided them for comparative purposes into 2 groups based on the presence or absence of alerts, and a decrease in SSAPs and MEPs greater than 50% was considered an alert, which is pretty standard. Alerts were, in this paper, were classified chronologically as either a type 1, type 2, or type 3. And these types were basically prior to decompression or during decompression and bony resection, or occurring at the osteotomy, at the time of osteotomy closure. So in this paper, SSEPs alerts occurred in 3 patients, and they also had significant MEP alerts, 2 type 1 to 15 type 2 and 6 type 3. And increasing the blood pressure improved their MEPs in all of the patients, with the exception of 8 of the type 2 alerts, which was during decompression, and 4 of the type 3 alerts, which is after our osteotomy closure. So basically unresponsive type 2 alerts, the ones that were happening during decompression, were all treated with osteotomy closure, with the expectation that the spinal shortening would decompress the spinal cord and improve spinal cord perfusion. So this was interesting because this is hearkening back to what happened during our case, where we felt that there was some stretch along the spinal cord, and during that we felt that with the spinal shortening, we would be able to decompress the cord and improve our neuromonitoring, and that actually did. That was the case for our patient. We'll keep going. This is from that same paper. This is showing the decline in MEPs, and then after osteotomy closure, showing increase in return of neuromonitoring signals. So I thought that was pretty apropos to our case as well. And then again, I mentioned last week that we had some issues with the nerve root. So when we resected, we clamped the T8 nerve root on the left and checked our motors approximately 3 minutes after we clamped that nerve root and radicular artery, and we didn't have any neuromonitoring changes after that time. So we went ahead and sacrificed the nerve root, and then only after several minutes after that, we began to start seeing neuromonitoring changes. So this was a case report that was interesting to me. So this showed a rare intraoperative spinal cord injury caused by thoracic 8 nerve root interruption during a posterior column resection, VCR. So this is just a case report, but again, it's the same level. It's a T8 nerve root, but this is during this patient had severe kyphoscoliosis, so a little bit of a different patient. But I'll walk through this a little bit. So when surgeons are performing an osteotomy in the thoracic region, the nerve root can often needs to be resected in order for ease of technical reasons to perform the vertebrectomy. Lenke et al. And other researchers have recommended placing temporary vascular clamps on the nerve root sleeve for 5 to 10 minutes while checking the spinal cord monitoring to make sure there's no changes. But there are few, if any, reports of intraoperative neuromonitoring events after interruption of the nerve root. So this is the case that they showed, and they basically they found that after they sacrificed the nerve root, approximately 8 minutes afterward, they had noted neuromonitoring changes on the convex side of the cord, and they felt that was basically due to stretch, to a stretch injury on the nerve on the spinal cord after it was sort of being untethered from that side. So this is kind of a little diagram of what they showed. So it's not exactly our same case, and I think that the reasons for our neuromonitoring changes are quite different from this case, in that we did not have any coronal plane deformity that may have been causing any type of stretch injury on the spinal cord, but it certainly was an interesting case to look at and to take note of this potential problem. And I don't know, I mean, we clamped it for 3 minutes, and in this case, they lost their signals after 8 minutes. So maybe the nerve root needs to be clamped for longer than that in the future, especially for severe coronal plane abnormalities where the stretch on the cord might be problematic. So thank you. Sorry, I tried to rush through that, make sure we have enough time for everything, but if anybody has any questions or comments.
Thanks, Rob. That's awesome. Great review.
Yeah.
Just real quick, a comment, like if you clamp a nerve root and the signals go out, what type of injury do you expect to the spinal cord?
If they go out right away, like you're saying?
Yeah, exactly. Like let's say you cut it, right, and then you lose signals. What kind of spinal cord injury would you anticipate?
I guess basically an hypoperfusion injury to the cord, or a stretch,
like a vascular
or a stretch injury. Like in this case, they weren't saying that it was a vascular injury. They're saying that it's a stretch injury on the contralateral side, because of the nerve root tension on the other side pulling on the tissue, the cord tissue.
Yeah.
So I think those
are all stretches, right? That's all. It's got to be a guess. But I think the one thing that you can probably rely on is if you have an intraoperative spinal cord injury from a vascular insult, I mean, you can probably even see that radiographically. You know what I mean? You'd probably be able to tell if you got an MRI.
Edema and everything.
Insult. Mm-hmm. Yeah. So I guess my point is like the vascular piece of it is the tricky part, because a lot of times those don't return. Many times those don't return because you interrupt the vascular supply, and then now you have a patients wake up with deficits that are usually longer lasting, if ever recoverable. So it's like an anterospinal artery syndrome, right?
Sure.
Those are classically don't do as well, or spinal cord stroke or things like that. So that's why I think at the end of this case, at our case at least, we thought probably not that, because he definitely had return of his function completely to baseline. So I would have anticipated at least some deficit. Because you have to put all those things in the context of what you end up experiencing on your own. But I think the point of clamping and waiting is a really good concept. Just God forbid.
Yeah, there's some other papers that I noted out there that showed just so much variability with regard to spinal perfusion anatomy. So, the dominant sort of blood supply to the, like as far as the artery of Damquitz could really be quite variable. So that was also something that I had come across. So kind of hard to know where the dominant supply is going to be coming in from. And if you're sacrificing those radicular arteries, you could be impacting it.
Awesome, dude. Appreciate it.
Yeah.